Dear colleagues, my name is Klemen Grablьевиц. I'm coming from University of Rehabilitation Institute of Slovenia. I greet you for your successful congress of your National PRM Society. And together with Professor Yanis Papatanasiou, we decided and chose the topic of today would be the frozen shoulder. Frozen shoulder is a major pathology in musculoskeletal physical and rehabilitation medicine clinics. And it's one of the most severe painful condition in musculoskeletal medicine. So probably it deserves to speak a little bit about the physiopathology, prognostic factors, and conservative treatment and outcome in this lecture. As I said before, the adhesive capsulitis, also well known as frozen shoulder, it's quite common, but actually poor research and very poor known pathological condition, which is characterized with severe pain, progressive limitation of active and passive range of motion of the glenohumeral joint without any pathological signs on X-ray. It has a long history of description and clinical problems. First time it was described in 1872 by Duplay as periarthritis humerus capillare. And in 1934, Codman introduced the very well-known term frozen shoulder. 10 years later, Nevazier introduced the term adhesive capsulitis, which is still in use today. You can find the condition under common terms as fibrotic capsulitis, primary idiopathic stiff shoulder, and contracture of the shoulder. As I said, there are three most important authors from the history describing frozen shoulder. The first one, Duplay, and well-known orthopedic surgeon Codman, and you can see here the original picture of the Codman pendulum exercises from 1934, which are still in use today. And then other synonyms in clinical practice, as I said, are fibrotic capsulitis, idiopathic stiff shoulder, and contracture of the shoulder. What's the pathogenesis of frozen shoulder? Of course, we need to look into the histology samples. And in samples of capsula, we will find a lot of fibroblasts and collagen type 1 and 3. Unfortunately, these fibroblasts can develop into the myofibroblast, which has a fine phenotype of the smooth muscle, which means they will contract, and from that we get a capsule contracture. There we will also find high concentration of inflammatory cytokines like interleukins, tumor necrosis factor, cyclooxygenase 1 and 2 in the tissue of the capsula and adjacent bursae, and also a high number of T cells, B cells, macrophages, and mast cells. And very important finding, which is a recent one, is the presence of the intercellular adhesion molecule 1, which is a transmembrane protein in capsula, in endothelial cells of capsula. That actually enables that leukocyte can migrate through the endothelium of these cells, and actually from that point we can really conclude that frozen shoulder is primary an inflammatory process leading to a capsular fibrosis. What are the risk factors to develop the frozen shoulder? In the literature, majority of the patients are female with the ratio 70-30. Age is important because majority of the patients in the studies are age 40 to 60 years. Majority of them are actually over 40. Previous injury to the shoulder joint, antibodies HLA-B27, prolonged immobilization. There are questions about the heredity and the race. I mean, it is known that in Caucasian race, white race, the incidence is higher than in other races. And of course, there is influence of endocrinial diseases like diabetes, thyroid disease, as well as stroke, and the presence of Dupuytren contracture. Speaking about the endocrine diseases in frozen shoulder, as we know, the prevalence of diabetes in general populations is between 2 and 5%, depends on the country and the study. But prevalence of frozen shoulder in the population of persons with diabetes 1 is 10% and diabetes 2 is 22%, which means 1 out of 5 diabetes 2 patients will have frozen shoulder. Which is really important. It's the prevalence of people with diabetes mellitus with frozen shoulders can be up to 30%. Unfortunately, also people with diabetes have a worse functional outcome of frozen shoulder treatment, and people with hyperthyroidism have a higher chance to develop frozen shoulder. About 25% of patients after stroke or subarachnoidal hemorrhage, they will develop frozen shoulder within 6 months. And that's a very, very high coincidence with the Dupuytren contracture and a frozen shoulder. When we speak about the adhesive capsulitis or frozen shoulder, we can divide it in primary or idiopathic without any obvious reason, and secondary frozen shoulder. And secondary, again, is divided to the reasons of systemic diseases and local shoulder pathology. Among systemic diseases, we already numbered diabetes, thyroid diseases, hypoadrenalism, also breast and chest surgeries, stroke, and heart diseases. But local shoulder pathology connected with frozen shoulder are tendinopathies and ruptures of the region of the rotator cuff, especially the partial tears, subacromial bursitis, tendinitis of the long head of biceps, fracture of humerus and fracture of clavicle, calcifying tendinitis, and prolonged immobilization. We know, or very well known, are 3 clinical stages of frozen shoulder. The first phase is so-called the freezing and very painful phase, with or without deficit of range of motion, and usually it takes 2 to 9 months to resolve. And I think it's very nice description of this phase. It's this very famous painting of Munch called Scream, and patients were really affected by the pain. The second phase is so-called frozen phase, which is transient, with a very limited range of motion, with or without pain, usually lasts 4 to 12 months. And the last phase is so-called thawing or melting phase, with decreased pain and improved mobility, and it can actually take a very long phase, up to 2 years. Nevertheless, I'm supporter of the theory that free-phase description of frozen shoulder is not very well defined. And I support the idea to use the description of the frozen shoulder better than free stages disease with full recovery as disease with short-term improvement, but it can take a long, ongoing, low-level restriction of pain and restriction and pain in the shoulder. And this would probably reduce the confusion of the patients when we describe this disease as strictly free phase with a limited time of duration, because unfortunately, in many cases, diseases doesn't go like that. So it's nice to explain to the patients that even there is a chance of a good resolution, there is also a chance that this will be a long-term disease with the potentially long-term disability and pain. So what do we set? How do we set the diagnosis of frozen shoulder? First, there's a history told by patients about sudden onset with shoulder pain, severe pain, or with limited shoulder motion, and the presence of night pain, which patient complained as limited sleep on affected side. In clinical status, we will find a reduced active and passive range of motion with most severely limited external rotation with a stiff end point. If we perform a simple X-ray, we will just rule out the severe osteoarthritis and posterior luxation, which could be very much different in history. The very effective diagnostics is ultrasound of the shoulder, which will at least rule out the rotator cuff damage and bursitis. And if you are experienced ultrasonographist, you can find thickening of the coracohumeral ligament and the thickening of the lower part of the capsula, as well axillary recesses, and some changes in the rotator interval, mostly in supraspinatus tendon. Of course, we can perform laboratory tests where we can find elevated SE and CRP, but MRI definitely is superior in case of frozen shoulder, because radiologist we will they will find edema of inferior glenohumeral ligament, thickening of the anterior branch of the same ligament, filament of the axillary recessus, and pericapsular edema. And I mean, the final and the gold standards, of course, MRI arthrography or CT arthrography, but usually the radiologist report of the difficult application of the contrast, and the amount of the contrast usual that goes into the joint is lower than usual. When we speak about the treatment, of course, definitely conservative is the first choice and very rarely operative. Conservative treatment consists of medication and physical therapy, and medication consists of the use of non-steroid anti-inflammatory drugs, oral corticosteroids, and intra-articular corticosteroids. Very, very useful treatment is a block of the suprascapular nerve under the ultrasound guidance. And very popular treatments today are intra-articular natrium hyaluronate, platelet-rich plasma injection, and of course, physical therapy. Among those, let's say, popular treatments, injection of natrium hyaluronate into the shoulder joint can show only short-term reduction of pain and improvement of functional mobility, so there's no long-term improvement. The suprascapular block with the anesthetics, it's significantly more effective on pain compared to placebo, and I can tell you this from my personal experiences. Use of PRP, platelet-rich plasma, in frozen shoulder. We don't have sufficient research. There are few case reports explaining improvement in range of motion and functional status and some reduction of pain during the day, but there's not enough evidence to support use of PRP currently in adhesive capsulitis. And high-intensity laser, not low laser, but high-intensity laser can bring short-term pain reduction, which means up to 2 months. Of course, treatment differs in different phases of frozen shoulder, and of course, in phase 1, we will work mostly on the pain relief for the patients and reduction of inflammation. Therefore, we will use non-steroids, anti-inflammatory drugs, oral corticosteroids even, and injection of corticosteroids, either subacromial, either intra-articular. Low-level laser therapy, electrotherapy, TENS, and acupuncture combined with therapeutic exercises can be used as well. But most important is information for the patients, education for the patient, which means we need to teach him how to change activities and inform him about the natural course of the disease, and to support him in performing different passive stretching exercises like oscillating exercising, which will keep scapulohumeral rhythm at least as normal as possible. In phase 2, we need to face the capsular adhesions. So we need to work on prevention of capsular adhesions and to improve range of motion and to correct irregular scapulohumeral rhythm, for which we will use active exercises up to the pain level and passive stretching exercising. And after improving mobility, we can go up to the exercises to strengthen the muscles, against the forced exercises, and we can use different joint mobilization techniques. In phase 3, of course, we will face already contracted structures in the shoulder, so we will work on the stretching with more intense exercises with pain degrees, and of course, it's very useful to apply heat packs pre-exercise. As we mentioned before, the surgical treatment is used only exceptionally, and this is reserved for the patients with persistent pain and severe limited passive mobility with fibrosis, who usually develop contracture of the joint and where the problems are persisting still 3 to 6 months after conservative therapy. And the typical surgery is arthroscopic global capsulotomy with circumferential rupture of the glenohumeral joint capsule and tissue resection of the rotator cuff and manipulation under anesthesia. And of course, it's understandable that intensive early physical therapy post-operation is very much important. Regarding the evidence of conservative therapy, of course, we usually look to the Cochrane Library. And what can Cochrane Library tell us about the good evidence on conservative treatment of frozen shoulder. Definitely the highest quality evidence is very simple. Just use physical therapy modalities and combine with exercises in frozen shoulder. The moderate evidence tells us that corticosteroid injection still reduce pain and improve function more than physical therapy and exercises, but the evidence is moderate. So we can add corticosteroid injection, especially intraarticular, to the physical therapy and exercises. And there's very low evidence, very low quality evidence that corticosteroids would actually reduce pain and improve function better than physical therapy, exercises, and electrotherapy. And physical therapy and exercises, electrotherapy, and corticosteroid injection do not work better than corticosteroids injection itself. Physical therapy, exercise, electrotherapy, non-steroids do not improve function more than oral non-steroids. But there are no research comparing the effect of exercises with the placebo effect. What about the mortalities for capsulitis? So there's very low evidence on low-level laser therapy, and also the pulse-electromagnetic therapy, and also the combination of low-level laser therapy and exercise. So actually, there's no much quality evidence for the treatment as here. What about injection techniques and acupuncture? Well, acupuncture by the Cochrane Library can improve pain and improve function short term, which means for 2 to 4 weeks after the session is finished. But as well, oral corticosteroids and subacromial and intraarticular corticosteroids can reduce pain and improve shoulder range of motion up to the 6-week. And speaking on intraarticular injections, the meta-analysis of many studies showed that, of course, intraarticular injection of corticosteroids can improve pain and function better than other non-surgical treatments and can last up to 6 months. Combination of intra-articular injection of corticosteroids and physical therapy has short-term effect on function. What is very important actually, that early application, which means when problems last less than 1 year, of intraarticular corticosteroids is associated with a better outcome than if injection is given later. And if actually we perform an injection, obviously that intraarticular corticosteroids has a better effect on pain than subacromial infiltration. And what are our experiences from Slovenia on treatment and follow-up of frozen shoulder? 2 years ago, we performed one of the longest-lasting follow-up studies in frozen shoulder in our patients. We included 25 patients, from those were 18 females, and only those with confirmed clinical and radiographic frozen shoulder were included, and we followed them for 2 years, which is one of the longest period of the follow-up in the literature. The average age of the patients when they were included in the study was 48.5 years, which is in correlation with the literature. And for the follow-up, we used shoulder pain and disability index, disability of arm, shoulder, and hand index. We followed the active and passive range of motion, and we measured the pain with visual analog scale. All patients, after the identifications, were included in multimodal physical therapy for 2 weeks in combination with non-steroid antirheumatic drugs, plus home exercises. They didn't receive any intraarticular therapy, which means we followed the recommendation of the Cochrane. And what we found out actually, that out of 25, 15 patients actually gained complete resolution, and majority of them only after 6 months, which was a good information for the therapy. Actually, the therapy we prescribed obviously was successful. 4 out of 15 were still better after 9 months. 3 out of 15 regained complete resolution after 12 months, and 1 still after 15 months. Unfortunately, in the last 9 months, there were no difference. So in the last 9 months of the study, no other patients gained complete resolution. So we concluded that majority of the subjects complete improvement and in functional status and reduction in pain were observed, which is good. 50% of those subjects did not require sick leave during all 3 phases of frozen shoulder. What was actually good and what we found out that we found previously unknown high glucose level in 5 out of 25 patients, which is 20% versus the regular incidence of diabetes in Slovenia, which is 5.9%. So definitely we suggested that serum glucose screening is recommended in all subjects with. So the conclusions of our study was that symptoms improved in the first year in a majority of the patients, which is a good news. And unfortunately, there's no important improvements in the second year. So the longer the disease lasts, less are the chances to get improved. And almost half of the patients were on sick leave for more than 3 months, which is quite a long time. But sick leave duration did not correlate with time to treatment initiation. And also our study showed that it is advisable to determine fasting blood sugar levels in patients with frozen shoulder as possible early in the. So, dear colleagues, thank you very much for your patience. Thank to you for all those who didn't get asleep during my lecture, and I would use this chance to present a little bit of activities of European Society for Physical and Rehabilitation Medicine. As I mentioned many times, the mission and goal of European Society for Physical and Rehabilitation Medicine is to bridge the gap between research and practice, and that's why we use congresses and national congresses to bring the knowledge to the local PRM community. And also the congresses are our bridge to bring the knowledge. So one of the next event organized by European Society is combined meeting with ISCOS, International Spinal Cord Society, which will be held November 19 to 20 in Ljubljana. There are still places to register, and you're very much welcome in my hometown. So from the side of society, please follow us on our social media and get all the information on the updated events regularly. Thank you very much.